Well, I started out as a pharmacist about 15 years ago, starting working in community pharmacy, so very much connected with people and working in a local community, which was really fulfilling and enjoyable. But I guess I got a bit of a bug to want to do something on a slightly larger scale, and so I started a PhD, went back to uni after a few years of working in the pharmacy, and studied how pharmacies manage change and how they implement services that they deliver to the consumers in their community. I think the biggest factor is this notion of an implementation gap. So you can have all the good services or programs in the world that you can show evidence for health outcomes, but if the consumer's not actually receiving them, it all comes to nothing. The exciting thing about Medicare locals is their lack of, or their focus on integration and the lack of silos that they have to deal with, because at a national level, the funding is kind of quarantined in specific areas for specific professions, or heart disease versus diabetes, whereas at a local level, the Medicare locals have the ability to be quite responsive to local needs. And I think one thing we've done really well here at Bayside Medicare Local is map those local needs, look at where those needs are not being met. And also we've got the capacity to join up other things like social determinants of health, things like transport, housing, all of those things that we know are important to those health outcomes, with the health services that are available, and join up the health professionals, because then you're looking at a whole of workforce approach rather than just saying, well, what can doctors do, what can pharmacists do? You're actually saying, what does the consumer need and how can that need be met?